Good day, everybody, and welcome. We're just going to wait a minute or two to make sure all participants have joined before we begin. Thanks for your patience. Okay, as I mentioned, we're just waiting another minute or so till we make sure all of our participants have joined. So thanks for your patience, and we'll begin in just a second. Okay, I think we're ready to begin. Good day, everybody, and welcome to our third and final webinar in the COVID and Mental Health Impacts, Lessons, and Opportunities series presented to you by the Young Leaders for Health organization. Today we'll be talking about COVID-19 and mental health, emerging research and treatments. And thank you for joining, and thanks for your time. Next slide, please. Before we launch into the webinar itself, I just wanted to go through a few housekeeping rules. So please use the chat function liberally. We have allocated quite some time at the end of the webinar for a discussion with our panelists, and we really encourage our attendees to submit questions and comments throughout the webinar, through their presentations, and in the panel discussion. And at the end, we will try to get to as many of the questions as we can. We are scheduled to go until 5 p.m. Central European time. But if we see that there are more questions and discussion taking place, we will keep going for a few minutes longer till a maximum of 5:30. So if you have time, we encourage you to stick around and listen to the conversation as it wraps up. Secondly, as with our previous webinars, this recording and slides will be circulated post-webinar on our website and through our social media channels. So make sure to take a look if you want to share it or take a look afterwards. And you can already find the recordings and summaries of the previous two webinars on our website. And if you would like to tweet, feel free to do so using hashtag #WhilehWebinars or hashtag #WhileHSDGs. So before we begin with a panel with the panelists, speakers, I would like to give a quick summary of WhileH and the mission and the vision of the organization. The Young Leaders for Health, our aim is to nurture the next generation of leaders in public and global health. So for those of you who aren't fully aware with the organization, we are an NGO, and yearly we organize generally a social entrepreneurship challenge on e-health in Berlin. This is to encourage young health enthusiasts to come together and make projects and real propositions on how to tackle current health issues. This year's topic of our social entrepreneurship challenge was meant to be mental health. When it became obvious that the challenge could not take place in person because of the COVID-19 pandemic, we decided as a team to keep our focus on mental health, that is ever more important in this period, and focus our efforts on new projects, including this webinar series. So this is our attempt to still spread some information in this new digital format. So if you go to the next slide. I'd like to just quickly summarize what were our previous two webinars about. In our first webinar, we discussed the impacts and psychosocial considerations for vulnerable populations during the pandemic. So we set the stage for mental distress during the COVID-19 pandemic, discussed mental health support for refugee women and the importance of women leadership in mental health. We concluded with a presentation on the inequalities that are killing Black Americans in the United States and a panel discussion with all the speakers, as we will today. In the second webinar, we listened to our speakers explain how the pandemic has stressed the need for universal health coverage. We also discussed mental health and the Sustainable Development Goals, highlighting the excessive mental health treatment gap in low and middle income countries. We heard country case studies pertaining to gaps in general and mental health resources and availability in Madagascar and Barbados. And don't forget, as I mentioned, that you can find a summary report and the recordings of the full webinars on our website and on YouTube. So in case you missed them and you are interested in going back and listening to the previous webinars or reading about them, please feel free to do so. Today, as you know, we will be discussing opportunities for digital and mental health, emerging research and treatments in light of this pandemic. So on the next slide, we can see an overview of today's agenda. We will hear from 4 really great speakers and end with a Q&A panel discussion as mentioned. And please do keep your comments and questions coming. First of all, we'll run through our speakers. First of all, will be Elliot Brown from the Young Leaders from Health organization. Next, we will have Dr. Stephen Chan, who I will introduce in more detail right before, but he's a clinical assistant professor at Stanford University School of Medicine. Next slide, we will also hear from Dr. Trina Histon, Senior Principal Consultant, Prevention and Wellness at Digital Health at Kaiser Permanente. And lastly, Dr. Pauline Whelan will speak, who is the co-director at CAMHS, Digital and Information Systems Program Manager. So should be super exciting. And at the end, we will have our panel discussion as mentioned. So first off, Elliot Brown from YLH will be giving us a quick intro on the relevance of digital mental health during COVID-19. So please, Elliot, take us away.
Thanks a lot, Marina. I just wanted to stop sharing my screen a second so you can see my face, because I don't actually have any slides. But hopefully you can hear me okay. And so I really just wanted to give a really brief introduction to the topic and try to put things a bit into context. But at the same time, I don't really want to take up too much time because we have a fantastic lineup of speakers today. And so, yeah, the topic is about the digitization of healthcare and specifically mental health care. And this has been growing for a while across the world, and at different rates. And different countries have been moving faster than others. And for example, here in Germany, this year has the Digital Care Act has just been introduced. And what that allows is for doctors to be able to prescribe digital health products just as they would regular treatments like pharmacological treatments. And then this would also be covered by health insurance companies. So this was really just introduced as in a response to a kind of previous lack of innovation in healthcare in Germany. And the higher powers kind of thought the country was a bit behind in other countries within Europe and across the world. And with the introduction of this new act, this has led to this huge surge of new products being developed, new startups being formed, and along with the COVID-19 pandemic, this has really just thrown fuel on this fire and has created a situation where certain aspects of the healthcare system have been really forced into digitization. And one of these areas is psychotherapy. People suffering from chronic mental illness who require regular psychotherapy have really been given the only option to continue their psychotherapy online. And I'm a big proponent of seeking mental health care, but there's still so many barriers that prevent many people from actually seeking help. And one of those big ones is really stigma. Another one being a general lack of resources relative to other forms, other healthcare. It's often the case that people just don't know where to look or how to find these resources. And even there's not so much awareness to allow people to be able to really define or categorize the kind of issues that they might be going through. And digital solutions can potentially provide a way out to a lot of these problems, and not just these problems, but also many others that the current healthcare system in many places might not be able to actually handle right now. And this kind of forced acceleration into digitization or forced innovation obviously has its pros and cons, and there's many, many new issues that come out of digitization up until now, and also there'll be a lot more coming out in the future. And a lot of these issues I think the speakers are going to be talking about today. And so today we're going to hear more specifically about, firstly, about how the pandemic has affected clinical practice. Then we're going to hear a bit about what an actual mental health ecosystem can look like. And then finally, we'll hear about how digital solutions can be implemented into an existing healthcare system. And so without further ado, I'll pass it back to Marina, who will share introduce our first speaker. And I'll just share the screen again in 1 second.
Thank you so much, Elliot, for the introduction. So as Elliot mentioned, we will be diving into the second of our panelists' presentations. First, we will have Stephen Chan. Stephen Chan is a clinical informaticist, psychiatrist, and medical director for addiction at Palo Alto VA Health, and is on faculty as clinical professor with Stanford University School of Medicine. He has published talks at Google, Yama, Telemedicine and eHealth, and the Journal of Medical Internet Research, Wired, PBS, NPR IdeaStream, and Mentor Power Hacks at mentalpowerhacks.com. So he has a very interesting presentation for us, and Stephen, please feel free to take us away.
Thank you so much. Let me, what I'm going to do is I'm going to mute my speaker so that I don't get the feedback. How is the sound? Is this any better?
That's great. Thank you, Stephen.
Okay. Just chat to me if there's something I need to follow up on. And I'm just checking the time to make sure that we have enough time for other speakers as well. My name's Steve. I'm so excited to be here, and I wanted to thank Dr. Brown, Marina, Claudia, and my colleagues for being on this panel with me. Right now, my primary appointment is at the VA Palo Alto, the Veterans Affairs, and we treat veterans of the United States. It's a single payer style system, but our exclusive patient population are veterans. And we have over 140 hospitals and medical centers across the United States, Hawaii, Puerto Rico, et cetera. And we have a fairly sizable population that's affected by mental health, post-traumatic stress disorder, as well as substance use disorders. But what I'll do is I'll speak from a lens of, as someone who's based in California, something that has been affecting the United States across my nation. So overview of the problem, what we'll do is we'll talk about some of the problems that we've encountered with the transition to digitization. And Dr. Brown had alluded to a lot of these issues that have come up since the COVID pandemic. And we'll also talk about some of the perspectives and how we've adjusted. I think we all remember how the iPhone has changed and transformed mobile devices. Since the iPhone has come out, there have been a lot of changes to the iPhone. They removed the headphone jack. They changed the adapters multiple times. And a lot of that came with a lot of adjustment and controversy. So it's easy to see as well how digitization can affect how we practice and how we work, and how there can be a lot of fatigue and pushback. One of the things that we've encountered is that this sudden rapid implementation leading to Zoom fatigue and change fatigue can affect how we implement more and more technologies. The sudden, fast regulatory and licensure changes have also been quite a whirlwind. And here what we've faced are a lot of different loosening of regulations, allowing us to use more cognitive behavioral therapy apps or CBT apps. The FDA is a regulatory agency in my country that regulates whether things may or may not be used in medical practice. There also has been new coding, which has implications for how we get reimbursed for the care we provide. And there has been a rapid expansion in the types of communication apps we can use. Before, we couldn't use Zoom, an unlicensed or version of, or free version of Zoom. And before, we couldn't use communication apps like FaceTime, but now we can in our practice. Connectivity and bandwidth are also issues that we face. Privacy and security fears. A lot of the folks that I serve, the patients I serve, may not have expressed that they do not want to install specific apps to communicate with me. Sometimes some of them rather show up in person, and despite the fact that the risks of the virus. And there is a lot of software complexity and faults. Yesterday, I must have had connectivity issues with almost every single patient I had. And if you think about all the different things that can go wrong, it's just like a face-to-face visit. Your automobile may break down, your train may break down, you might not get to the clinic on time. So too, we have these issues with technology. So if you go to the next slide, take a look at the workflow. The typical workflow for having someone come to see you in person is outlined in blue in these boxes. And usually if someone wants to see a clinician, they might experience distress, they may make an appointment with your clinic, they may wait for your appointment. And then finally, when they're in your office as a clinician, they might want to discuss symptoms, and then you'd finally figure out a treatment option, and through shared decision-making, decide on a treatment. So the boxes in green and red show all the touch points that technology, that COVID-19 actually has ushered in terms of the changes. So if we look at the red boxes, COVID-19 has caused limitations on hospital access. COVID-19 has caused, at least in my country, a lack of protective equipment, personal protective equipment, PPE. COVID-19 has caused issues for those who have no smartphone or webcam. COVID-19 has also caused, has made it more difficult to do a mental status exam over technology. But COVID-19 has also ushered some changes in the way we deliver healthcare by telehealth. In green, you'll see that since the digitization, we don't have to worry about transportation barriers anymore. With digital technology, we can conduct visits over video. With telehealth, we can conduct email or messaging instructions. With some of the loosening of restrictions, we've been able to mail medicines, particularly some of the controlled substances that we typically would have to do in person. And we can also recommend apps and video services. So the next slide shows that in general, from my perspective and from my colleagues' perspectives, the box in green at the top right corner, the green, some of the good things that have come out are that with telehealth, we can do more efficient charting. And there's also no exposure to this virus. In fact, I would say technology has become our protective equipment. But the downsides in red, that pink red box, a lot of tech support, a lot of IT calls have had to be made, a lot of organizational changes, a lot of monitoring for regulatory, policy, and licensure changes. And in terms of clinical practice, we've had limited access to things that we'd have to do in person, urine drug screens and breathalyzers particularly. And since we can't see our colleagues very easily, there's been a lot more loneliness, uncertainty, anxiety, and stress. So there have been a lot of regulations that have changed within the United States. For instance, all the acronyms are either agencies or medical societies. VA is Veterans Affairs, that's my health system. And so some of the adjustments that we've seen are telephone and telehealth initiation for a medicine called buprenorphine. And buprenorphine is a life-saving medicine. I don't have any stock in this or financial interest in this, but we've seen it transform people's lives with heroin addiction, opiate addiction, But they've got all these regulations around how we give buprenorphine. And so with COVID-19, a lot of we've been able to more easily provide that care. Again, use of non-HIPAA compliant communication platforms. HIPAA, it stands for the Healthcare Insurance Portability, and I forget the last two acronym letters, but this particular regulation dictates how we share information. And within the United States, we're not able to readily disclose someone's information without their permission. So it protects patients, but it also restricts which technologies we can use. And we've also adjusted by using different means of identifying whether someone is diverting their medicines, whether they're taking medicines and then reselling them or giving them away. Everything's on digital platforms now. We want to reduce infection risk. So the next slide shows 3 panels on the right-hand side. And this is from the New England Journal of Medicine, a very, very, I would say one of the top-ranked medical journals, NEJM. This particular one is from a former president of the American Telemedicine Association, listing the types of telehealth tools that we can categorize: clinician to clinician in green, clinician to patient in red, and then in purple, patient to mobile health technology. So if you're thinking about how the business case or the research cases around these tools, telemedicine and telehealth, mental health, telepsychiatry, telepsychology, those are all umbrella terms for the specific tools that can be used in our toolbox. And I won't go into specific details for each one, but suffice to say, clinician to clinician tools have already been in widespread use. Now we're seeing a rapid uptake of clinician to patient tools as a substitute for face-to-face visits, and patient to mobile health technology. Those are some of the self-help technologies, smartphone apps, Apple Health, Samsung Health, and even video games now that are being developed for helping treat attention issues, etc. And then on the left-hand side shows some of the things that I've been also working on in terms of patient to mobile health technology in the realm of self-help education. So in the next slide, I would say that in general, when you look and you take into we'll hear from our other speakers too, how we would need to take into account the viewpoints of the patients that we serve. Patients so far have expressed to me, for instance, that they like the technology because they can keep safe from exposure. They find it more convenient. Our catchment area is wide. We have a large rural population, so they don't have to do 3-hour bus and train rides. They love the continuity. They love the increased access, especially with group therapy. And we have Zoom calls, for instance, with 30 or more people on the call. And it has been an extraordinary experience for people who are not able to get here in person. But some folks still do not like the experience. POTS is plain old telephone system. That's a technical term. Some still want the telephone experience. And fortunately, some of our video conferencing platforms, not all, but some of them do allow telephone access. There's more forgetfulness, I would say, with the appointments because they treat it as more of an impromptu phone call. It does require a certain level of technology and proficiency. There's varying software quality, and I can certainly attest to a lot of the crashiness that we have faced with some of our software. And finally, with COVID-19, community living has been difficult. Our homeless shelters and our residential settings have been deemed high risk for the spread of virus. So those are our perspectives in terms of COVID-19. I want to hand it off to Dr. Histon to talk about the next steps in transforming care.
Thanks, Dr. Chan, and hi everybody. I'm calling in from about an hour north of where Dr. Chan is sitting. I'm in San Francisco, and thanks to Dr. Brown and the team at Young Leaders for Health for the invitation to spend time with you today. And I'm looking forward to the conversation we're going to have. I co-lead a project that is deploying a digital mental health ecosystem of tools within Kaiser Permanente. For those of you that aren't familiar with us, we're America's one of America's largest and oldest nonprofit integrated delivery systems, and we actually partner quite a bit with the VA, where Dr. Chan is right now, and we take care of about 12 million lives. Just to kind of give you some perspective on that. And so the journey I want to share with you today, if we start on the next slide, has been one that we've been on for quite a while, and this particular project has been going for about 3.5 years, and I'll speak to the changes in COVID when we get to it. So I would say everything Dr. Chan shared resonated very strongly with me in terms of our own experience within Kaiser Permanente. But I want to first anchor us in sort of a stress continuum model, and this is taken from first responders training in the United States. And I think in a pre-COVID environment, you know, we could segment the population, which we tend to do a lot in healthcare. We have segmentation strategies. So here from left to right, you'll see, you know, people going on about their lives and not continuing to make healthy choices. They're fully in their lives. They're with their families. They're, you know, working. They're able to have many good days, and then maybe there are some persistent days where there's distress, and they might move into that reacting column. And so the goal there is to leverage your resiliency skills and get back to that sort of ready bucket, if you will, as soon as you can. But you know, we all as humans experience, you know, mild distress and you know, poor focus, loss of interest. That's part of being a human being. And then as we go along the continuum, then you start to see some of the more subclinical things we think about, like depression, anxiety, you know, adjustment disorder, you know, show up, and you know, actively beginning to heal from those journeys. Maybe there's more social isolation, but if those persist, then we certainly can get up into that sort of ill bucket, where people actually reach out and get help. And we know from the published literature and from our own talking to our own therapists that, you know, people wait a long time to seek care. And we know that just globally, the amount of, you know, therapists, psychiatrists we have is never enough to meet the demand that we're seeing globally. And I would say pre-COVID, about 40% of folks would be in the sort of healthy category, 35% would be subclinical, as we'd call it, and then about 25% might be in that higher care continuum there to the right-hand side, having a diagnosis, with about 45% of those folks maybe having more than one disorder. They'd have two. So in the COVID timeframe, what we've seen is a shift toward the right-hand side there, with more people feeling that distress, just given pretty much how our lives have been altered dramatically. But I want to anchor us in Kaiser Permanente's model, and you know, because we're an integrated system, I'll sort of draw your attention to the center there, where our members, as we call them, also maybe known as patients when they start to seek care, you know, are part of a care team, and they're kind of surrounded by that care team. And so rather than use a continuum model, we're using an ecosystem model, because I think it allows for more permeability. When we think of continuums, we almost think that people stay kind of stuck in those boxes. But we know in the real world, people move around a lot more, and there's a lot more flux. And so, you know, going from the inside to the very outer side, as we moved into a time in COVID, we have a lot more folks seeking, you know, self-care and wellness resources, and they could be in the form of mental health classes, they could be wellness coaching, which we offer, and they could be apps, digital self-help tools. And then as we go around sort of into primary care, you know, your partnership with your primary care doctor, and sort of visiting with them if you need to, you know, all the way through the continuum of if you need more intensive services, if you have a diagnosis of depression or anxiety. And I would say in a pre-COVID environment, from a telemedicine perspective and all the things Dr. Chan spoke to, and we probably had over 30% of our members availing of video visits and phone visits as part of their normal path of care. But very quickly in COVID, we pivoted to be able to deliver more than 80% of our care model virtually. And that came with a lot of the sort of growing pains, if you will, and issues that Dr. Chan referenced. But I would say, you know, by and large, for many systems in the United States, you know, as an industry, healthcare is risk averse, and we probably did a decade's worth of innovation in a matter of a month, due to necessity of COVID, and, you know, keeping our care team safe and also keeping our members safe by being able to take care of their healthcare needs virtually. So as Dr. Chan referenced, they didn't have to travel to us, and also our care teams didn't have to kind of be in their normal milieu. But we want to make sure that we don't lose anything in that process. So this is the sort of ecosystem of care that we think about, and it enables us to, you know, really tailor a treatment plan for a member, and it also has agency for the member to sort of seek out different things that they will need to keep themselves healthy. And so on the next slide, I'll speak a little bit more about the work that I'm involved in. And so with the work we've been doing in digital mental health, one of the things we discovered about 3.5 years ago was we wanted to be able to create a standardized suite of tools for our therapists and our psychiatrists to be able to refer members to via our electronic medical record. It's called KP Health Connect. It's an Epic product if you're familiar with EMRs. And we wanted to be able to kind of refresh and modernize the toolbox for our clinicians. And so in the curated resources there in the green box at the top, we have 6 apps that we're working with under a digital health umbrella. Some would be considered digital health tools, and others would be considered digital therapeutics, and they're cognitive behavioral therapy apps. And we also have some mindfulness meditation apps. The other thing we heard from members and therapists using human-centered design as the engine for learning was there was a desire to have more content on our member-facing website, which is called kp.org. And more audio, because people were consuming, you know, podcasts and TED Talks, and they sort of wanted that, their health information in those formats too. And then refreshing on articles. Prior to the work we've done, things were clinically framed, which is entirely appropriate for a healthcare organization. But we heard again from therapists and members, you know, how about we can frame the issues in my life circumstance, like parenting stress or caregiving stress, or relationship issues, or, you know, I'm not sleeping well, what's going on and how can I get back to a normal pattern? So the work we've done has leaned very heavily into our clinical processes and our clinical pathways, and we really have used human-centered design, iterating with our therapists and our members to make sure what we're building is easy for the care teams to make a referral, but it's also easy for our members to receive, and really leveraging all the technology. Given over 80% of Americans own a smartphone, you sort of have a delivery mechanism in people's hands that we want to be able to leverage. And also, I'd say about 1.5 years ago, the notion of, well, can we have a subset of these apps available as self-serve, so you don't necessarily have to be tethering to an office visit with a therapist or a psychiatrist, but, you know, you're going through moments of your definition of distress, and you want to, you know, some self-help. And so we embarked on an ability to build out that functionality in more detail on kp.org. And so the next slide sort of shows you some of the member-facing work that we've done to make these tools more available to our over 12 million members. So if we can show the next slide, that would be great. What I'm sharing with you now is, this is sort of a picture of the homepage. As I mentioned, we've refreshed articles in English and in Spanish, audio activities, videos, self-assessment tools if people want to do their own PHQ-9, which is a depression screener, and they can see how they're doing. And then you'll notice 2 of the 6 apps in our digital formulary, Calm and My Strength. And Calm may have name recognition because it started its life as a consumer-facing mindfulness meditation tool, and it is very, very popular. And then My Strength is a cognitive behavioral therapy tool. It's part of the Livongo suite of programming. And so this is now available to more of our members. And I would say, you know, in the time of COVID, what we've seen is a rapid increase in people wanting to get those self-care resources, but we've also seen and built out functionality in our EMR for non-behavioral healthcare settings to make referrals to these 2 tools. That's primary care, you know, OB-GYN, in internal medicine. Anybody who isn't a behavioral health specialist actually wanted access to be able to give these tools, because as care has transferred to virtual, the normal ways of sort of showing empathy within a doctor office visit, like leaning in and making eye contact, those have been a little more difficult to achieve in a virtual setting. And our doctors reflected that we'd like to be able to put Now that we're virtual, we want some more tools in our digital toolbox. So we've seen a huge increase in a desire for digital tools. So I'm very optimistic for the field of digital health and for digital mental health, just given the pivot we've made to meet the needs of the moment we're living through globally, and how we can do that. And sort of on the next slide, and I believe this is my last slide, you know, one of the questions I get asked a lot is, how did you choose the 6? And I will say that in our early days, the American Psychiatric Association had criteria for how you choose a good app, and they've actually just refreshed it and released a database. So if you look at the latest issue of Nature Digital Medicine, you'll see a new article on the app evaluation model, which nicely summarizes the work that's been happening over the last several years. And then the other thing that's happened is employer groups in the United States, as part of their wellness offering, really stepped into this digital mental health space more rapidly than maybe health systems have. Often health systems, being more risk averse, are slower to adopt these newer approaches. And so they've got a lot of experience. And Cyber Guide with the P has released also a very nice toolkit about how you might make an informed decision on which apps to use. And in our early days, we wanted to focus on meditation, mindfulness, and cognitive behavioral therapy, simply because the evidence base was the most robust for those two. And we also, in addition to how these tools were translating the evidence base and their early outcomes, the user experience for these tools is very important. You could have the best tool in the world, but if the UX is very clunky, and we see this with some of the more maybe academically framed tools, great tools, but people drop out at rapid levels. The evidence base would suggest 90% of people stop using a digital mental health tool within 2 weeks. And that's often because the user experience is not good. And we all have apps on our phone that we started using that we've given up on, or we maybe didn't even open after we downloaded it. Another very important consideration, and Dr. Chan touched on the importance of HIPAA, and you know, healthcare is a very regulated industry in the United States. You know, making sure that we didn't want to work with apps that were free, simply because often the revenue model is to sell that data onwards. So ensuring that the contracts you have with app companies don't allow sharing with third parties. And you know, think about whether you need an app that's self-guided or an app that might have a coach or a therapist as part of that. And again, I mentioned Cyber Guide and the APA as now 2 systems, looking to Germany with great interest to see how the deployment of the Digital Health Act there is going to go. And obviously in the UK, NICE has released a nice framework for how you evaluate these tools. So countries are really stepping up to provide clarity on what's a very noisy space, and that I think will see even more uptake of these tools. So that sort of concludes my introductory remarks, and I think I'm handing it over to Dr. Whelan now to share her work in the UK.
Thank you, Trina. If I can just, Pauline, give you a quick introduction. So thank you both, Dr. Stephen and Dr. Trina Histon, for those interesting speeches, and I'm looking forward to talking to you in more detail during our discussion. Before that, we will, yes, definitely hear from Dr. Pauline Whelan, the CA on the CAMHS Digital Research Unit, Digital Mental Health for Children and Young People, which I think is also an extremely relevant topic at the moment. Dr. Whelan is co-director of the CAMHS Digital Research Unit at Greater Manchester Mental Health NHS Foundation Trust. She's also the digital health technical lead on the digital health software team and co-lead of the Connected Health academic team at the Centre for Health Informatics at the University of Manchester. So without any further ado, Pauline, the stage is yours. I'm looking forward to it.
Thanks very much, and thanks very much for the invitation to this webinar today. It's been really interesting so far to hear the US perspective on the responses to COVID. So I'm going to talk about the work of our CAMHS Digital Research Unit. We're a research unit at Greater Manchester Mental Health NHS Foundation Trust. For people who don't know, Greater Manchester is a region in the northwest of England, and Greater Manchester Mental Health is an NHS trust, so it's a publicly funded mental health service provided to a population of about 1.2 million people living across the areas of Bolton, Salford, Trafford and Manchester. And over a 12-month period, the trust sees in the region of about 50,000 service users, many of whom are children and young people. And it's also one of the most active research trusts in the UK, with one of the highest levels of recruitment, for example, into clinical trials for mental health. So we're very keen as a trust to keep staff and service users at the leading edge of new mental health research. The CAM's Digital Research Unit is one of 9 research units, and we're affiliated to the University of Manchester, so specifically to the Centre for Women's Mental Health and to the Centre for Health Informatics, which is where I'm partly based. Our focus is on digital mental health and well-being for children and young people, and we work in partnership with children and young people, roughly between the ages of 8 to 24. CAM, so CAMHS, stands for Child and Adolescent Mental Health Services. But our remit is not really just mental health services. We're very much interested in young people's mental health and well-being more broadly, so right across the spectrum of mental health and well-being. Increasingly, since COVID-19, we're working in partnership with the clinical teams at the Trust to try and develop a digital and innovation pipeline in light really of the surge of interest in digital mental health and the ongoing need for remote delivery of services. And overall, the unit really wants to provide our young people with the skills and the opportunities to shape and drive the digital mental health research agenda for the work that we do. Next slide, please. In terms of the digital side of digital mental health, we're really almost technology agnostic. So we want to use technology that benefits and supports our young people population rather than being technology led as such. Although I need to confess that I'm a computer scientist by background, so I am very interested, very interested in the digital tech and in new digital innovations. And in my other role, I lead a team of software engineers and designers building different kinds of digital tech for health research. But as a research unit, we're interested in, for example, mobile apps for self-management of various conditions. We're interested in using wearables for understanding how patterns of physical activity and sleep may relate to patterns of mental well-being. We're interested in virtual reality. We think about how machine learning might be useful in terms of risk prediction and so on. To give you an idea of some of the projects we've worked on with our young people, so recently we prototyped together a self-harm, self-management mobile app using augmented reality. And this was really as a response to the rising rates of self-harm among young people in the UK and the recognition that mental health services are overstretched and that help is often needed out of hours. So augmented reality seemed to allow us a way to deliver a personalized, context-rich environment for young people that could be an immersive experience that they could access on demand when services weren't available. So we worked with our young people and with industry experts in augmented reality to co-design the app through a series of interactive user-centered workshops. Next slide, please. So this slide shows our general model of working. Children and young people are obviously at the heart of the process and the heart of everything that we do. Prior to the COVID-19 outbreak, we were meeting monthly face-to-face at the University of Manchester premises with our, what we call Digital Research Advisory Group of young people. So we have about 50 young people in the group. Attendance at meetings can vary anything between about 5 young people and 30 young people, depending on the topic and whether people are away. But now we meet weekly via Zoom. So we meet every Wednesday between 4 and 5 on Zoom because we can't meet face-to-face. And in terms of collaboration, we work with industry partners, so new innovators in digital health. We work with software companies like the augmented reality experts that we talked about earlier. We work with mental health services and clinical teams. We work with national mental health organizations as well as charities, and obviously our academic partners and industries across the UK and internationally. We aim to develop a range of creative outputs through our various projects, as well as digital tech, of course. So as well as the prototypes that I mentioned earlier, at the moment, to give an example, we're working with a young animator alongside our group of young people to develop animations around the safe collection and sharing of mental health data for research. So obviously as researchers, we're really interested in collecting mental health data from people, but we need to understand the conditions that young people will feel safe sharing their mental health data with us. So we've also run a number of citizen jury style workshops, so highly participatory style workshops to understand the views of young people around sharing mental health data for research purposes. Next slide, please. One of our areas of focus is the translation of research into clinical practice. So we want our research to be relevant and useful to clinical practice. And that includes things like considering implementation frameworks, so things like the NAS framework that's quite popular in digital mental health, at least in the UK, and understanding how technology can be sustainably embedded into mental health services. And that obviously throws up a number of challenges for us. One of the newer initiatives that we've adopted in this area is developing a digital navigator stream across GMMH. So this is about developing a new care team member, in our case, a volunteer young person, who can help with embedding and using the new digital technologies within services. So the digital navigator model, and this is a model that we've drawn on, Wisniewski and Torres's model from the US, about evaluating and recommending new technologies for use in services, providing training and support to clinicians and service users on digital technologies, helping to troubleshoot the tech when there are problems, enabling clinicians to focus on time spent with the patient, enabling them to explain data and provide an overview of some of the more complex digital dashboards that clinicians are presented with. So we provide training to young people, training around trust safeguarding and safe working practices, for example, or training around evaluation frameworks for digital tech, or how to use the digital tech, or how to troubleshoot common problems, and how to assist clinical teams in understanding the tech. And then in terms of supporting the CAMS teams, so they can assist in the evaluation of digital tech or provide digital assistance or help them to understand the data. And the goal really is to free up the clinical teams to enable them to deliver clinical care, but to provide the digital support that might be lacking and might not be able to be delivered through the mental health services otherwise. Next slide, please. So just say thanks very much for listening, and thanks again for the invitation to join this webinar today. It's a fantastic initiative. If anyone is interested further in the work that we do, please get in touch.
Thank you so much. I want to take this moment to thank all of our panelists for the wonderful presentations. Dr. Stephen Chan for outlining the challenges faced by digital mental health services, and how he and regulatory bodies in the US in particular have adapted to the current pandemic. To Dr. Trina Histon, who elaborated on the speed and extent of changes that she has seen in the last month, including all the improvements in digital self-care tools and all the resources she mentioned. And finally, Dr. Pauline Whelan, who talked to us about how she and her colleagues at Greater Manchester Mental Health have used technical innovations to help when working on the mental health of children and adolescents in the UK. So thank you very much again. I'd like to now begin our panel discussion and remind our audience that you are encouraged to use the Zoom chat function we have in the call to send any comments or questions you may have for one or all of our panelists. And yes, thank you all of you for turning on your cameras so now we can see you. So I thought to start our discussion on a positive note, could you just maybe perhaps go through and give us talk to us about accomplishments that you're particularly proud of or just happy about in general from this year in regards to adapting to the COVID-19 pandemic, whatever it may be it from your professional history or just what you see in general happening globally. Maybe go in the same order as the speeches. So Dr. Stephen Chan, if you would like to start us off, go for it.
I'm letting me unmute. Can you hear me okay?
Yeah. Yes.
Okay. Turned out I had two Zoom windows open, one as an audience member and one as a participant, so that's why there was some feedback. I think the greatest accomplishment has been that our primarily services have been face-to-face. We serve veterans who come in distress, who really enjoy the community atmosphere and seeing each other as well. We've been able to that also applies to our staff members as well. But since the transition, we've had to hide behind masks. We've also had to really use computers and smartphones much more extensively. I think the greatest accomplishment has been to continue to maintain trust and communication amongst our staff, the people that we serve. And the trust helps reduce anxiety, reduce stress, and boost morale. And that's something that I know is a challenge and a barrier towards for people who telework in traditional settings, traditional work settings. So I'd say maintaining trust and also communication has been the most important accomplishment.
Yeah, that certainly resonates. I would say accomplishments are twofold. I think one is, since we're all living through this global experience and perhaps each country is addressing the pandemic a little differently, I would say there's been a willingness and an openness to talk about the struggles people are having. So it's normalized as part of a human experience that maybe you're not sleeping as well, maybe you're experiencing more symptoms of anxiety or depression, and you're talking about it. So I actually see an opportunity here for further stigma reduction, because more and more people are feeling that persistent distress due to pandemic life and the adjustment that we've all had to make And I think there are a lot of positives in that, now there'll be more empathy, I hope, for people who live with these issues maybe more persistently in their lives. So that's sort of one upside. And in fact, I was listening to Michelle Obama's new podcast yesterday, and she even spoke about, you know, the low-grade depression she was feeling as part of having to make adjustments in pandemic life and having her kids at home. So even a former First Lady can, you know, normalize what it feels like to live through a pandemic. And I think that's a huge positive. I think that on the system side, you know, in the time of COVID-19, you know, when we're training therapists and psychiatrists, we were doing it face-to-face. We would bring them nice food because that's important, and spend time together face-to-face and answer all the questions. And there's just something about being in a room with a group of clinicians that you just can have a different kind of conversation. And so we then had to pivot. We've literally increased our referring provider pool into our ecosystem conservative by 300% in the time of COVID, and done it all virtually, but not necessarily seen any decay in referral enrollment or engagement rates in the digital tools. So I think that's a huge accomplishment, to be able to pivot everything to be virtual and then still hold the line on a quality of making a referral and of a member receiving that, and hearing the stories from our members about how these tools have just shown up just at the right time in their lives when they were having trouble sleeping, etc. So they're two positives that I see in the time of COVID.
Thanks. And I think from my side, there's two general things I'd say. One is, I think there's a much greater awareness and a much greater optimism about the use of digital technology to support mental health and well-being than there has been previously. I've been working in digital health for quite a long time, and the argument has shifted recently, so we no longer really need to argue so much about the benefits of digital mental health. People accept that now, that there can be benefits. It's about implementation and how do we do that. And the second thing is really about a growing appreciation, I think, of the complexity of embedding digital technology within mental health services. It is really, really challenging, and it's difficult to get it right. And I think there's been a bit of a naivety about how to do that previously, and I think people are gradually becoming aware of just how complex that is. So people understand that it's not a one-size-fits-all approach. There is a need for personalization, there's a need for blended approaches. And I think there are definitely, maybe not accomplishments, but positive things to come from this year.
Thanks so much, everyone. And thanks so much for your great talks. I didn't get a chance to thank you. I just have another question that we had kind of mentioned before, and I think some of you have already kind of touched on a little bit, but I was wondering what you think are the major kind of challenges or barriers right now that you're currently facing, that were either there before the pandemic or maybe came as a result of the pandemic, and what you think a potential solution might be to kind of break down the barrier and help move things forward. Maybe we can go backwards and start with Dr. Whelan.
Sure. So I think one of the problems, I think, is still finding and evaluating good evidence-based digital technology. So there are evaluation frameworks, and I know Trina's mentioned the NICE framework, which is very useful, and there's other frameworks out there as well, but it's still a very difficult challenge for mental health services to choose and select digital technology that has a robust evidence base, but is still user-friendly, has been through a co-production process, has good data security, and is keeping up to date with all the changes. So even if something complies with all that at the time of selection and procurement, it's got to be kept up to date. So I think that's probably one of the biggest challenges that we're facing at the moment.
Yeah, I certainly, that resonates quite a bit with me in terms of how do you know what good looks like. There's a lot of noise in digital in general, and there's, you know, I'm an hour away from Silicon Valley, so there's a lot of hype. And so there's a culture clash, I guess, that we think about. In medicine, we think of first, do no harm. And then, you know, an hour down in Silicon Valley, it's like move fast and break things. And that can often be like, oof, that's antithetical to how we think about healthcare. However, in our learning, you know, stepping into a space together to explore how do we meet unmet needs in new ways that are that have efficacy, that begin to show effectiveness, because I think we're still early in the digital health journey. It's quite nascent, but also can meet needs in new ways. So one of the exciting things has been, we've deployed these tools within our standard, care pathways. And I do think there are new models of care that will emerge from how you leverage a therapist and an app together. And there are some, like you mentioned, Pauline, Dr. John Touros at Beth Israel Deaconess and his digital health clinic. There are some programs and protocols being developed that do that. And I think that brings us to a new space. From the implementation literature that Pauline referenced, we know that confidence, belief, and acceptance that these tools could actually help people was low. And also, how do you fit this into your workflow and your EMR? Huge issues to solve for there that we leaned into pretty heavily using human-centered design as part of our deployment. And I think that's why we have so many clinicians referring to these tools, because we obviously give them access to them themselves, so they get over the belief and confidence piece, and they see, oh, cognitive restructuring and CBT, I like how you've done that exercise, and they're more likely to embed it in their plan of care, in working with the member. And so that's an iterative process. And the other, I think, challenge in healthcare that may be perceived as a barrier, if you're prescribing a medication, that medication 10 milligram pill in January is the same pill in September. And that's not true of digital therapeutics. A good tool will be iterating, learning from its user base, adding new features, and so on and so forth. And that's new for healthcare to think about. It's like, what do you mean your product is going to be different in 4 months' time? But the value prop there is, and this is something we've experienced, is you actually get to influence the product roadmap for those apps, and you get to get more of the tools you feel will be useful to support your members in the care plans you're building. So in a barrier, the flip side of the barrier is the opportunity, and I tend to be an optimist, so I look for the opportunities. But they're some of the things that I think make it difficult to enter into the space of digital. It's like, where's the evidence, what's the value, and am I listening to hype, or am I actually listening to something that has an evidence base behind it? And there's still, even though we frameworks, we're still early in determining what good looks like.
So one of the barriers I see with particularly digital health technologies is that a lot of the software that we deem as low risk and also not subject to regulation by the FDA may not follow, like, say, evidence-based practices for usability. So if you take sort of systems as simple as video conferencing, system X, Y, and Z, Z's for Zoom, it's really astounding how much Zoom has eaten Skype's lunch and every single other video conferencing system's lunch, so much that I get 2 requests from patients, hey, why can't we just Zoom? Or why can't we just FaceTime? And the ease of use and the lack of barriers, the technical and usability barriers, and the amount of clicks that it takes to get to what you want is quite astounding. So I would like to see a lot of evidence-based practice for usability and user interface design be applied to clinician technologies and video conferencing technologies especially. Every single little permission checkbox and setting is a potential roadblock for a patient, as well as every single click. I've measured it takes us 60 to 70 clicks within our system just to schedule a video appointment. And I'm not going to name names, but it's astounding how simple usability practice could really improve people's perception of healthcare and reduce frustration, but also we've had folks who just disengage entirely and say, just call me on the telephone, because they don't want to deal with all the headaches. And so we need to get those other technologies right. And we also see this with informaticists and clinical informatics. It is a colossal headache to implement apps within a specific electronic health record system. Can take over a year, if not longer, just to do that. And they're not simply plug and play. So I've had conversations with chief medical informatics officers who tell me, don't even bother interfacing with the EHR. First, the EHR might change. Second, they keep on upgrading. For instance, there's a well-known vendor in the Midwest who does quarterly upgrades now, and so things are prone to breakage, and so that's another big issue: interoperability and then user interface design too. And I would love, love, love to see that be a requirement for purchasing in the future.
Thank you all for your answers. Clearly, you're also all, I can see you nodding in agreement with each other, so it's clear that the challenges are unanimous, but I'm happy to hear that also there are some steps being taken. We have quite some interesting questions coming from our panel, from our attendees, actually. I'll just read one from one anonymous attendee that says, "Thank you all for your thought-provoking presentations. A question: what needs to happen so that the wide reach and near ubiquitous use of social media platforms can afford novel opportunities to address shortfalls in existing mental health care?" Anybody has some thoughts on the use of, clearly the widespread social media use in addressing mental health care gaps?
I could sort of maybe say a few things about it. Social media platforms are, as we can see, a wide open canvas. I myself subscribe to a lot of physicians, psychologists, etc. And so I'm subject to doom scrolling, where I'm looking at scrolling through article after article of doom and gloom, because I subscribe to healthcare professionals. When I talk to my sister, who manages 200 grocery stores in California and their social media, she says, no, my Facebook feed is all about food because she manages grocery stores. So it would be interesting if we harness the power of social media platforms to put guardrails such that we specifically encourage positive mental health, pro-mental health posts, for instance, or perhaps using the FTC model. FTC is an agency in the United States that mandates our communications. And one of the requirements they have of television broadcasts is education programming. Every single station has to have a specific number of hours of educational programming. So wouldn't it be nice if they did something, would it be interesting if they did something similar with social media platforms, which is our generation's television?
I would say within sort of Kaiser Permanente, sort of two things I think about. As part of our anti-stigma campaign, we've created findyourwords.org, and it really is looking at how are you communicating with your colleagues and your friends, and even on social media, to sort of indicate, how you're doing. I think I'm watching with interest how GDPR kind of plays out in Europe. I think there are regulatory mechanisms that are being stood up in Europe that the US is just going in a different direction, and we'll see where that goes with the big 3 or 4 companies. I would say the other thing we've done is go where young people are, and so we've partnered with Cloud9, which is a gaming company, and working with some gamers that are often on Twitch and in these gaming channels, where a lot of the language of gaming can be very negatively framed. And so working with influencers and gamers and reaching young people that way is another strategy that we've decided to deploy, because the algorithms in social media are sophisticated, and it's difficult to have a unified experience that way. So go where the people are is important, I think, in terms of our learnings for that. And we're still early in understanding. We think about Instagram, we think about Facebook, but now you've got TikTok, and now you've got Snapchat and other programming that like 15-second segments. So what can you really achieve in that time frame? And it's such a rapidly moving space.
If you like, we can move on to the next question. But unless Dr. Whelan had something you wanted to say?
I don't have a lot to add to that. I think most of the points have been covered very well by Stephen and Trina. I would say, I guess, from a research perspective, analyzing social media data is always difficult because of the ethics and consent needed around accessing data. And the other challenge, I suppose, is that the data is held by commercial third parties, which throws up other challenges. So from a research perspective, I do have colleagues working on analyzing social media data, but there are specific challenges there that make it rather complex.
I will point out in the published literature, we've seen some papers where people who might be going to the ED, you know, with the psychiatric diagnosis, being willing to allow access to their social media feeds that then gets merged with their EMR data. So there are some papers that show high acceptance from folks in the ED, and then there's some early work on predictive modeling to see, could we predict when somebody might be you know, having a downward spiral sooner than when they show up in the ED. So that's just some early work I've seen published, but not quite sure, you know, where that's going, or but at least there's acceptance for sharing the data from the patient's perspective.
Great, thanks a lot. And I just wanted to ask, before we continue, it's now just gone past the hour, and we had originally planned in an hour for the webinar. So I just wanted to give any of the speakers the opportunity, if they have any prior engagements, then please don't hesitate to leave. But if you're happy to answer a couple more questions, then maybe we could go on for another 15-20 minutes or so. Yeah, but in the meantime, if you want to sneak out, then please feel free to. It's yeah, we won't think you're rude. It's okay. And we really appreciate your contributions already. So so we're kind of pushing the boat out a bit now. But yeah, there was a question actually from Victor in the chat, who asked specifically about regulations, and it was something that I thought would be really interesting to ask you, because we have Dr. Whelan from the UK and Dr. Histon and Chan in the US. You must have had very different experiences with regulations of new digital products, but also something that I've been wondering about a lot, with this idea that we have, that everything is so new, and the way that we're collecting data is new, and the way that the kind of context that medical products are in now is new, and I think a lot of the issues that are coming up are things that maybe we couldn't have predicted in the past, just because of new innovations. And I think maybe in the future there could be also these kind of unpredictable issues coming up that we couldn't really prepare for, and we couldn't really create regulations for to safeguard us when these things come up. So I was just wondering what you think, what your current experiences have been so far, and what you think the kind of how things might play out in the future.
I'm happy to reflect on that. I would say in the ecosystem we've built, you know, we have some tools that are considered digital therapeutics, and I think there's clearer guidance for companies who want to pursue that pathway and FDA approval, and groups like the Digital Therapeutic Alliance, which is a nonprofit group of that's bringing a degree of rigor to the process and developing frameworks and what the evidence base needs to look like, and also working and partnering with the FDA. Back in, I'd say it was March or April, the FDA released you know, companies that were going to be used for addressing psychiatric issues, if I can use their verbiage, and freeing it from final approval. So that meant more products were available to be on the market, you know, without the final sort of hurdle, if you will, of the approval process. And I would say, obviously, the FDA is a very important organization from a regulatory perspective in the United States, and in health systems, we have even more layers of what we care about. So, you know, things we think about having a technical risk review, because if you're partnering with any organization external to your own, you know, care model, you want to make sure that those companies are also meeting additional standards. So I'd say the FDA is foundational, but it's not sufficient in terms of everything you want to look at from a health systems perspective. So I think it depends on the digital product. If you're a consumer-based product, you're not collecting any health data, you know, you're providing you know, tools and skills, but you're not assessing depression, anxiety, there's no sensor as part of your data collection, you're different as a product to one that says they're digital therapeutic. You would expect a reliance on and a very clear path of how the evidence base has been translated, a very clear path on how you are showing reliable symptom reduction for depression, anxiety, you would expect randomized control trial data. And, I think the quality of the studies is getting better, which is good news. And you would expect a reliable reduction in symptoms from a digital therapeutic. So you would hold that to a different standard. And so they're often under the same umbrella as digital health, but not all things are created equal.
Just to add from a UK perspective, so in the UK, it's the MHRA, the Medicines and Healthcare Regulatory Agency, that regulates the software as a medical device. And a lot comes down to the purpose of the software. So if it is an active diagnostic or therapeutic tool, then it will be regulated as a medical device. And again, there's different classifications of risk depending on what the software is designed to do. So even from a research perspective, we've developed some software that is classified as a medical device for research purposes. And again, we have to go through the process there of negotiating with the MHRA and going through all the risk reviews and making sure that we develop the software to the process that meet the standards that the MHRA require, which in general are the software standards that we apply anyway, but obviously the process for this is a lot more regulated, so you need to document everything that you're doing and make sure that you comply with what they've laid out. There's a very helpful flowchart on the MHRA website actually that describes exactly whether or not your software will be classified as a medical device. So if anybody's developing software and curious as to whether or not it would be classified in the UK as a medical device, I recommend the MHRA website, which has a really straightforward flowchart. Oh, sometimes the devil's in the details and it's not always that straightforward. There's lots of gray areas, but it's a helpful start if people want a bit more information.
Yeah, and just to add to that, we, not just the FDA, but we also have the federal, the FTC, as well as the ONC and some other agencies. So there are tools on the federal government website that will allow you, for the United States, that will allow you to show you whether your software or your app is subject to a specific type of regulation. So for instance, if your software claims to do X, Y, and Z, it actually falls not under the FDA, but some other agency, the FTC. The FDA has also released some software as a medical device documents and guidance. I think the most recent one was about 2 months ago, where they outline and provide in a very clear table general wellness products that are low risk. You think about, like, say, a conversion of it's kind of like a self-help book with general advice on general wellness, healthy activities, low risk sort of things, all the way to software as a medical device or software in a medical device, SAMD or SIMD, that will be regulated. Anything that can, that has an implantable sensor, just as Dr. Histon had mentioned, things like blood pressure, any sort of quantifiable sort of states. And then adding on to that, is this enough regulation, the technical requirements? I'm part of a consortium called Advice Health, ADVICE Health, and it's based out of the University of California, San Francisco, UCSF, and we're developing a digital health common application that will take a lot of these metrics into account, but it's very much in its infancy. We're still working with some other health systems as well. And it's something that I think that that would help streamline a lot of the noise. Unfortunately, I have to bow out, but I wanted to thank everyone for being part of this. I'll let the conversation continue.
Great, lovely to meet you, Dr. Chen.
Thank you very much, Dr.
Be
Chen.
in touch.
Take care.
Well, maybe we have time. We have a lot of really great questions coming up, actually. Unfortunately, we won't be able to get through all of them, I'm sure. But if anyone from the attendees would like to reach out to us, or we will try our best to get back to you in the future with answers to your questions. Since we are already at 15 past, maybe we can just end with one question I thought was actually quite interesting from Anton and our attendees. If you could tackle one priority problem within the digital mental health sector, which one would it be and how would you start tackling it? I know.
That's a good question.
It's a good question.
I also see Faye Sahai is on. Hi, Faye. Nice to see you attending. I would say tackling youth mental health needs. And simply because in the United States, data shows suicide is actually the second highest cause of death in 10 to 24-year-olds. And we know if we speak with adults who have a diagnosis of depression, anxiety, what have you, often the roots of that is in their earlier years. If we can catch that, first instance, or even prevent it, frankly, and really, have a good treatment model, a good support system, good skill building, we're going to reduce the burden of suffering at a population level in untold ways. And we also know that younger age group is experiencing mental health conditions at much, much higher rates than we've ever seen before. So I would say really addressing youth needs and supporting that population would be a priority.
As our research unit is focused on youth mental health, I can't but agree with that. But to turn the question a little bit, I think the other big area for me is addressing health inequalities. And I think that's actually one area where digital can really help us. So making things more accessible on demand when other services aren't available, helping overstretched services, and providing a personalized, context-rich environment for people. I think digital can really help us there.
I agree.
That's great. I agree definitely with all of your points. Perhaps we can actually, there's also one question that I thought was quite relevant in this period. If there are any digital mental health tools targeted for health professionals, and particularly frontline workers during the pandemic, which I think is also if you know of any, which I think is a very targeted question as well.
Yeah, specific apps, I don't think I could name specific apps, but I do know, there's sort of a wraparound of a suite of supports. So the digital mental health tools that I've referenced today are available to anybody if you're a KP member or your KP staff, and that would include our frontline teams. But I think, in addition, is supporting the frontline teams in the experiences they're going through. Like, they've trained to save lives, and I have just so much respect for the work they're doing right now. And they're many months into this and not seeing, certainly in the United States with the numbers, any break on the horizon. So, we know PTSD and, not sleeping well and, anxiety are also prevalent in our staff, and they're so professional in how they do their work. So really ensuring we're supporting the work that they need to do, which includes, having those conversations that they now need to have. It's almost like, end of life care discussions that they may have to have with someone in their 20s or their 30s, and ensuring that the supports of how they can navigate those conversations, and then how that feels for them as professionals who have gone to train to save lives, and now they're dealing with the hardest parts of this pandemic. So things that really look to PTSD, address sleep issues, address anxiety in the near term. And we're going to continue to learn about needs as we go through this pandemic, because we're still in the midst of it. But they're things that are top of mind, almost having a trauma-informed care approach to how care is delivered in hospitals where our care teams are taking care of the sickest folks with COVID-19.
I think from my side, it's maybe not about highlighting specific apps or tools, but I guess there are some things we're using at GMMH at the moment around visualizing and managing caseloads and helping to highlight individuals at risk using algorithms, which frontline professionals are finding really helpful. Most of the apps that service users will use obviously have a clinician interface, which hopefully assists the clinician as well. So it's a two-pronged approach, but I don't think there's specific tools I would recommend.
Yeah, great question.
Well, thank you both. I think we'll start wrapping up, as unfortunately we are well past our allocated time, but I do see some more interesting questions from the audience about transitioning to VR in the future, even outside of a pandemic context, and what solutions there are for the elderly and so on. And so I think it would be great to continue this conversation. Obviously, these conversations need to continue generally, maybe in a digital format as in this period, and on our social media platforms and so on. So we will try to continue these conversations. So please do follow, and to our attendees, if you have any other ones than these, we will try to get some answers for you. Really happy to see the engagement. So to wrap up, I definitely would like to thank our incredible panelists for their adept presentations and insights during the discussion. I also want to thank our attendees for their really great questions and for taking the time for your interest and for your questions. I hope you have all found the discussion interesting and informative, and yeah, definitely get in touch with us and follow on social media to continue our conversations. As mentioned, we will be posting this video and a summary of the webinar on our site, as we already have done for our 2 previous webinars, so feel free to go take a look and share and refer to any of them in the future. Make sure to follow us on LinkedIn or Facebook, wherever you're comfortable, to find out about our next events and the rescheduling of our Social Entrepreneurship Challenge next year. The challenge was actually meant to begin today on August 6th in Berlin. So we're really happy that instead we've had the pleasure of hosting this informative and important series, and hope you've all enjoyed it as much as we have and can use it for reference in the future. And yeah, that you can keep in touch with us and we connect with you in the future on any future projects that we're working on. And with that, I want to thank everybody again and conclude our COVID-19 and mental health impacts, lessons, and opportunities series, and wish you a wonderful day and the rest of your weeks, and hope to see you all in the future again. Thank you very much. And thank you for everyone commenting. It's really been a great session, and happy to see so much interaction from our audience. All the best.
Thanks for having us. Take care.
Bye.
Best of luck. Bye-bye.
Thanks.